Okay, good afternoon, everyone. I hope everybody was able to join. I want to thank you for joining, and I want to welcome our faculty. First, Dr. Marie Kruger, my co-moderator this evening, and our three speakers, Professor Ludwig Zrinzo, Professor Patrick Plumstead, and Professor Marta Dell'Alamo. Today's webinar will focus on the role of lesioning surgery in the modern landscape of functional neurosurgery. And despite the rise of neuromodulation therapies, lesioning remains a valuable option for specific conditions and patients, especially when DBS is not possible or not available, and when immediate symptom relief is needed. And we've just come back from a 2-day course that was dedicated to lesioning, the noble art of lesioning, that I strongly recommend to anyone interested in the field. The next one will be in 2 years' time. And as we will discuss, advances in technology, imaging, and targeting methods have made lesioning a safe and effective tool. And it's clear that lesioning will continue to be a valuable part in the armamentarium of functional neurosurgery to improve patients' outcome worldwide. So we will start the webinar. Our first speaker is Professor Ludwig Zrinzo. He is the head of the functional neurosurgery unit in the UCL London, Queen Square. He specializes in different aspects of functional neurosurgery, and his research has been directed towards improving safety, accuracy, and efficiency of stereotactic surgery. Today, he's going to share with us his extensive experience in radiofrequency lesioning for movement disorders. So please, Ludwig.
Hi, first of all, thank you very much for that very kind introduction, and welcome to all the participants for this EANS webinar. So the title that I've been asked to speak about is radiofrequency ablation for movement disorders, and I must have a conflict of interest here because it's one of my favorite operations. I think that it can be extremely effective when used in the right patients, and it's underutilized. And there's a resurgence in this technique, and I like to think that the number of people who are attending today shows that that interest is increasing. So if we think about functional neurosurgery, I mean, the beginning of functional neurosurgery was lesions. But for many decades, that was taken over by deep brain stimulation. If we look at lesions back in the 1940s and 50s and 60s, radiofrequency ablation was king. And for a number of decades, radiofrequency ablation, together with other ablation methods like cryoprecipitation or alcohol or procaine, were used to make strategic lesions in neural circuits to help patients with movement disorders. Following radiofrequency ablation and other needle ablations, gamma knife surgery, another ablation method, was introduced and lit. And it's really thanks to MR-guided focused ultrasound that there has been a resurgence of interest in lesions. Because if we look at this timeline, we can see that although the interest in lesions increased through the 20th century, it really peaked around the year 2000, and deep brain stimulation overtook radiofrequency ablation as the primary method of treating patients with movement disorders, primarily because it was very safe in bilateral procedures, and many patients with movement disorders have bilateral symptoms. And you can see in this graph here that the number of publications for radiofrequency ablation really dropped after the year 2000 and only started to increase again, nay, exploded, after the first publication of MR-guided focused ultrasound for tremor, not so long ago, just over 10 years ago. And there really has been a huge interest in lesioning. And I think radiofrequency ablation is making a comeback thanks to the interest in MR-guided focused ultrasound. We have to remember that most of the literature on radiofrequency ablation was comes from the ventriculography era, which has sometimes been called blind radiofrequency ablation. You're aiming for a target that you can't see and that you had to infer from landmarks that you got from ventriculography, and then confirm that you were in the right place with an awake patient using clinical science, but also electrophysiological studies. And what I'd like to convince you is that radiofrequency ablation is a modern technique, but it's only modern when it's married with modern imaging criteria, tech tools, such as MRI. And because we're using magnetic resonance imaging to guide our surgery, we can't rely on the radiologists to do our job for us. We have to empower ourselves to understand how we can improve our imaging, how we can see the targets we're trying to hit, and we have to understand how we can minimize the pitfalls of a radiology, such as problems with fusing images and co-registration problems, problems such as MR distortion, and we need to be aware of these and master them so that we can maximize the utility of MR technology. So just like we have MR-guided focused ultrasound, now I think we have to emphasize that we have MR-guided radiofrequency ablation. And if we go through the literature, there's a useful review of the literature looking at stereotactic surgery for essential tremor, the various modalities used, looking at deep brain stimulation, focused ultrasound, gamma knife, and the fourth column you can see in that table is radiofrequency. And strikingly, only 2 of those studies were after the year 2000. So there are very few patients from the modern non-ventriculography era. But then if we look at the tremor control, we can see that RF ablation is among the highest unilateral tremor control. So it's extremely effective, despite the fact that most of the data is coming from an era and we couldn't see the target. The corollary of that, though, is that the side effects are quite high. And those side effects were high, I suspect, because we were aiming for something that we could not see. And as we know, if we're targeting the ventral intermediate nucleus of the thalamus, the motor part of the thalamus, there are lots of important structures surrounding that, such as the capsule just laterally, the sensory thalamus just posteriorly, and you can get problems such as dysarthria, paresthesia, hemiparesis, if your ablation is not in the right spot. However, again, this is from the ventriculography or blind radiofrequency ablation era, and we have to reinvent this technique by marrying it with imaging. So I think nowadays we should be talking about MR-guided radiofrequency ablation, not using simply landmark targeting. I think landmarks can be very useful. So there are many ways of distinguishing where the ventral intermediate nucleus is on an atlas. One common way is saying it's 14 millimeters from the midline, 6 millimeters in front of the posterior commissure, round about at the ACP level or 1 millimeter below. Others use the distance from the ventricular wall, as you can see in the picture on the left, of 11 millimeters. And others still use ratios. So you take the ACPC length and divide it into quarters or thirds and do mathematical algorithms to come to the coordinates. And they all bring you approximately in the same space. But one has to do intraoperative clinical testing to define that you're in the right target. But I'd like to convince you on the right, this is what we call an FAT1 image, that we can see contrast within the thalamus. And quite clearly here we can see structures that correlate with the ventral oral nucleus, the ventral intermediate nucleus, and the posterior sensory nuclei, with the posterior commissure being over there, and clearly seeing the lateral border with the capsule. And of course, if you're able to see a target, you're much more likely to hit it. I would insist on performing awake surgery wherever you can when you're performing an ablation, because no matter how good your targeting is, you really want to make sure that you're not going to cause any bad side effects before you ablate the brain permanently. This is something that DBS is superior to radiofrequency ablation in the sense that you can always relocate a poorly placed electrode, but you can't relocate a poorly placed lesion. So I'd just like to mention Harith Akram, who's another one of the functional neurosurgeons at Queen Square, together with Marie and I. And he was instrumental in developing this FAT1 image, which is a fraction anisotropy map fused with T1 data. And we're leveraging the data that you get from fractional anisotropy, which is something that we use to look at tracts within the brain, together with structural data. And over many averages, you can actually reduce the amount of artifact that you get from movement if the patient has minor movement within the scanner. So I'd urge you to have a look at this paper that we published only last year to see how you can leverage advanced imaging to make your task easier when targeting the VIM. But you don't need to access difficult or advanced imaging techniques to see the VIM. And there's a very good paper by Francisco Ponce's group, that's now a few years old, looking at proton density images. And proton density is a type of scan that allows you to see white matter and gray matter with great detail. So if we have a look at the inset here, you can see very clearly the posterior limb of the internal capsule. And if you go just 1 millimeter below the ACPC, you can see the fibers entering the VIM, and we think this dark area here represents the dentatorthalamic tract on its way into the VIM nucleus of the thalamus. And you don't need a 3T scanner, as Francisco Ponce used. This is a 1.5 Tesla proton density scan, and within 7 minutes, you can get this very high contrast within the thalamus. You can see very nicely this triangle, which is a hypo-intensity that delineates the dentatorthalamic tract on its way into the VIM. And I'd just like to point out the huge asymmetry of the VIM on one side here, and you can see that the VIM on this side is much more posterior than the VIM on the other side. And if you were to use atlas coordinates to find the VIM, you would have very different outcomes when it comes to accuracy of targeting the VIM on both sides. So if we can outline the VIM very nicely, and what we try to aim for is the most posterior and lateral part of the VIM to get the best efficacy out of it. I think it's important to talk about the practical aspects of radiofrequency ablation. I've actually mucked up the slides here. Let's talk about the principles first. So we've known about the principles of radiofrequency ablation for over half a century now. And essentially what you're doing is you're placing an electrode with a bare tip, in other words, a non-insulated tip, into the brain tissue, and you're passing a very high frequency current through that of around 500,000 hertz. And what this essentially does is it forces the charged particles, the ions, in the tissues surrounding that tip to oscillate so quickly within the tissues that the friction that it generates within the cellular structure causes heat dissipation, and that heat causes coagulation of protein and causes that tissue to die. So you are not heating the tip of the probe, you are actually heating the tissues. But then you have a thermistor in the tip of the probe that can calculate the temperature or the heat energy that is being passed back into the probe, and therefore you have a mode of control, so you make sure that you don't have too high temperatures. So what you really want to do is to make a lesion which coagulates the tissues, but without vaporizing the fluid in the tissues. If you give too much energy, you'll cause vaporization of the water, which will cause popping and charring, and you end up with the tissues adhering to the probe. And of course, if you have a vessel that adheres to the side of the probe, when you pull that out, you can cause a bleed. And therefore, you have to be careful about the rate of energy that you're delivering. You have to be careful about the maximum temperature that you're delivering. And you have to understand that the size of your lesion will depend on the size of the probe, the distance of the tissues from the tip of the probe, the current intensity with the amperage that you're putting through, and the duration. So most lesions are made at around 70 to 80 degrees, keeping the temperature there for around 40 seconds. And once you've reached a steady state where you're applying energy, but the energy is being dissipated by CSF or blood or distance, then you have that balance of the lesion and it won't continue to grow. So very often there's no point heating the tissues for more than 30 or 40 seconds because you're not going to cause more tissue damage. Here is just a summary of some of the things we've said. That most lesions are made between 60 and 80 degrees. Larger tips create larger lesions, and you've got to be careful of the power that you're giving. So how do we go about doing radiofrequency ablation for tremor, which is by far the most common lesion that we make? Well, first of all, we place a frame on the head. We tend to prefer the Vantage frame just because it leaves the face of the patient nice and free over here. It's much less claustrophobic for the patient. And also you want to examine clinical signs, including eye movements of the patient, and this allows you the freedom to do so. And then we obtain a 3T MRI, that's what we have access to in our institution, and we obtain proton density scans in both the axial and the coronal dimensions, as well as an FAT1 scan preoperatively. And then we visualize the VIM, and we place our lesion location 1 millimeter below the ACPC line, and we try and make sure that we're at least 3 millimeters away from the internal capsule to avoid any heat going into the internal capsule and causing weakness or hemiparesis. Here is a short video just to show the steps of what we do. So here we are plugging in the atlas coordinates, which gives us a rough estimate of where the VIM will be. As you can see here, we are pretty much on the visualized VIM, so we don't have to make too many alterations, although we do tend to round off the numbers on the stereotactic frame to make them easier to program into the frame. We then blend those images with the a previously obtained FAT1 map, and you can see here we're checking that the distance from the capsule is about 3 millimeters. And then post-operatively, we will fuse the lesion with the intended target, and you can see the lesion is pretty much bang on to where we wanted to make it. So the surgery itself consists of placing a burr hole in the line of the trajectory. We then implant the probe and we observe for a stun effect. And this is a patient that Marie was operating on with one of her fellows. And you can see here that the tremor is fairly severe. And as the probe is introduced into the target, we can see that as soon as we reach the target, Marie's now saying, let's turn the probe a little bit to cause a little bit of more of a stun effect, a microlesion effect. You can see a dramatic effect on the tremor, despite not stimulating and not making a thermal lesion. There's still a little bit of tremor there, but as time passes, the edema will increase and the tremor resolves even further. So when you get a result like this, you know that a small lesion at that target is likely to have a really good long-term outcome. We then will stimulate through the electrode, and we're not only looking for an effect on the tremor, but we're also looking for potential side effects. So we actually use fairly large stimulation parameters of about 500 milliseconds up to 130 hertz. And what we're looking for is capsular side effects, and we know that our probe is too lateral, or continuing sensory side effects, and then we know that our probe is too posterior. You will get sensory phenomena within the palm itself, which are transient when you're in the motor thalamus, because the motor thalamus is a sensory motor structure, and you will get transient sensory tingling, ideally within the palm of the patient. And we have an example here of a lady with severe tremor, and you can see that we try to get them to do ADLs, we try to get them to drink, we try to get them to write, and here, very hard. You can see at 2 milliamps, we've got this very clear capsular effect. And once we turn the stimulation off, she can now open and close the hand very easily. When we've moved the probe, we've moved that medially, you can see that we now have very good control of tremor without any capsular effect. I would point out here that it's quite rare to see this very clear capsular effect in the hand. Usually the signs are more subtle, and what we ask patients to do is to open and close the hand and say whether that's easy or difficult to do, and then when you withdraw the current, if there was a capsular effect, they'll say, oh, suddenly it's a little bit easier to move my hand. So you have to look out for these capsular side effects. We also look for eye movements to make sure that there isn't any problems with the frontal eye field projections. And it's really important to interact with your patient to make sure that you're going to get a good effect without any side effects. Continued tingling is a bad sign, because if you lesion the sensory thalamus as well as the motor thalamus, you might get rid of the tremor, but the hand will be useless, because without the sensory feedback from the hand, you won't be able to do your ADLs, your activities of daily living. So this is just a paper that we published with the clinical outcomes of radiofrequency at our institution. You can see that there is a small regression of tremor over time, but a continued beneficial effect in the treated hand at long-term outcome, but with a very significantly low side effect profile.
Try to bring your arm up higher.
Tremor can be treated depending on different etiologies. So this is an example of MS tremor. You can see with a very severe ataxia on top of the tremor.
Okay, and back towards your nose.
And then if we play the other video for time, you can see that there's a very huge improvement in tremor. And more importantly, she can do things like drink, which gives her an independence that she didn't have before. Just another example of Holmes tremor, just to say that you can treat almost any sort of tremor by lesioning the VIM, but this is a specific example because the local anatomy was distorted by this very large cavernoma at the conjunction of the midbrain and the thalamus. So using atlas coordinates would have been absolutely impossible with this patient because the anatomy is distorted. But by using connectivity targeting, we could define where the VIM is based on its connectivity to the contralateral dentate nucleus and the ipsilateral motor area. And we can see here, if I advance the video, a very stunning improvement in Holt's tremor by making that lesion, which is much higher than one would normally make for VIM, because the VIM is being pushed up to the level of the foramen of Monroe over here, with gratifying improvement in the tremor. So it's not just about thalamotomy. Pallidotomy is a wonderful procedure which is unfortunately used very rarely these days, despite the fact that there's very strong class 1 evidence of efficacy. Pallidotomy is really good for hyperkinetic disorders, really good for Parkinson's disease, where dyskinesia is a side effect of the medication. And again, there are many nuances about pallidotomy that I won't go into given its constraints of time. But you can save somebody's life if they have a dystonic crises because of, for example, an infected DBS system that has to be removed by performing a pallidotomy. And there have been cases where patients have died because the local team didn't know how to perform a pallidotomy when DBS had to be withdrawn acutely. The pallidothalamic tract is actually an old target, which is being revived by specifically Takataira's group from Tokyo. It's used in a number of hyperkinetic disorders. And essentially what we can see here is that the pallidum, if you perform a pallidotomy, you are essentially destroying the outflow of the pallidum, and that includes the ansa lenticularis, which goes around the cerebral peduncle, and the lenticular fasciculus, which goes through the internal capsule. And these two meet in Forel's field just inferior to the thalamus between the STN and the mammillothalamic tract. And what we can see here on the Schaltenbrand atlas is the mammillothalamic tract, the tail, the dorsal, the superior tail of the STN, and Forel's field, the pallidothalamic tract just between them. So you can use these two landmarks at the ACPC line to identify. You can see the mammillothalamic tract and just the tail of the STN there with this pallidothalamic tractotomy. And this is a very useful procedure which has very similar effects to pallidotomy, but provides more proximal control of dyskinetic movements. The VOP is the portion of the thalamus that receives the pallidal outflow, and this can be used for task-specific dystonia. And again, Takataira's group has many hundreds of patients who have task-specific dystonia, like a musician's dystonia, that can be treated in such a fashion. I put this slide up to say that you can perform bilateral radiofrequency ablation, but you should never do that at the same time. It should always be staged with at least 6 months in between them. And the side effect profile of bilateral ablation is much higher, about 3 to 6 times higher than unilateral ablation. So one has to think very carefully before performing bilateral ablations. However, it can be done successfully. And I show you here an example of an old lesion, which is just this tiny white dot here in the VIM, and an acute lesion when we performed the contralateral side. The biggest problem can be with swallowing, and that can be life-threatening, and more commonly problems with balance and gait. So think very carefully before performing bilateral ablations, and make sure you have a huge experience of unilateral ablations before you even dare to do that. If you are doing bilateral ablations, there's this idea from the literature that if you do asymmetric ablations, you are less likely to cause axial side effects. And there's this excellent paper from Kiev, from Kostiantin Kostyuk, who have performed 28 bilateral interventions. But note that this was done in 418 patients who underwent unilateral ablation. So it's a highly selected group of patients who they felt could tolerate bilateral ablations, and they did asymmetric ablation. So first doing a VIM on one side, and then doing either the STN or, if very dyskinetic, the pallidum on the other side, with really quite impressive results. So we'll hear a little bit more from our other speakers about focused ultrasound, but I think it's really important to consider that we have many tools in our toolbox, whether that's radiofrequency ablation, gamma knife, performing lit, or performing focused ultrasound. These are all different ways of making a lesion, but this really is the cheapest way. Radiofrequency ablation is really the cheapest way of making a lesion. You buy a lesion generator, which is measured in the tens of thousands of euros, and then you can use non-disposable radiofrequency ablation lesions, needles. So there really is no ongoing cost to radiofrequency ablation. Whereas things like the gamma knife, you're paying millions for the machine. Of course, you're not just using it for tremor. But for focused ultrasound, the main indication is tremor, and you're paying millions of capital outlay with hundreds of thousands of pounds in maintenance over the lifetime of the machine. And of course, lit catheters are very expensive too. So radiofrequency ablation is a much cheaper solution, is not necessarily inferior to more modern, so to speak, lesion techniques. So again, I won't dwell on this because I don't want to take too much more time, but each modality has its advantages and disadvantages. Don't have to shave for radiofrequency ablation compared to shaving the head for focused ultrasound. And what is important to the patient. And I think therefore, if we have all of these tools and we can offer the advantages and disadvantages, or describe the advantages and disadvantages of each technique to the patient, then we empower the patient to make a selection that is best for them. So I'll summarize with this slide. Why would you choose radiofrequency ablation over DBS or indeed focused ultrasound? Well, if you have predominant unilateral symptoms, then ablation really is a fantastic tool. If patients don't want to have implanted hardware, there are many reasons why they might not want to have that. Or if there are contraindications to deep brain stimulation, if they've got terribly controlled diabetes or very thin skin, or they have mental health issues which will preclude careful follow-up. If they have significant balance or speech problems, then DBS is probably a much safer option. But if there are none of these, then in good hands, radiofrequency ablation may be the better option. I'll state again that ablation should always be staged and unilateral if speech and balance are impaired after the first procedure. Improvement of quality of life is really the most when you treat the dominant hand. And the dogma for many years was you don't need your other hand if your dominant hand is free from tremor. But nowadays that might have changed. Using a mobile phone, it really requires both hands to be relatively free of tremor, and therefore many patients come back asking for the other hand to be treated because they want to hold their mobile phone. I'll say again that radiofrequency ablation can be a life-saving procedure in DBS failure, and I think if you're doing regular DBS, you really should know how to do an RF ablation. So this is a massively important but neglected tool in our toolbox, and I'd urge you to go and visit a center and learn how to do this if you're interested in having or setting up a functional neurosurgery service. So I'll say a big thank you to the whole team that I work with in London, and my mentor, Marwan Haris, who was very gracious in teaching me this ancient noble art of lesioning, which is very modern when compiled with MR imaging. And I just urge you to come and visit Queen Square if you like. We have a simulation course later on in October, which will cover DBS, but a large proportion of it is also dedicated to radiofrequency ablation. And with that, I thank you for your time.
Thank you very much, Ludwig. That was a very nice overview on radiofrequency ablation, also one of my favorite operations. What we'll do is we will just continue with the next speaker, and then we will take all the questions in the end. So for those of you who are watching, please feel free to start typing your questions in the chat, but we will do the questions in the end. So I will introduce our next speaker, Professor Patrick Blomstedt. He's the head of the Stereotactic and Functional Department in Umeå in Sweden. They have a decade of experience with deep brain stimulation, but they've also acquired a FUS machine and have a lot of experience with that. So he's going to talk about specifically the treatment of tremor with focused ultrasound. I'd also like to point out that Patrick is the father of the Stereotactic and Academy, which is an online platform which has hundreds of videos on stereotactic and functional procedures. So if you haven't had a chance to look at it, please go there. It is really a fantastic collection of teaching material. With this, I'd like to hand over to you, Patrick. Thanks for joining us tonight.
Thank you, Marie. I'm joining you, as you know, from a hotel room in Marseille, and I have some computer problems. So I have actually prepared a video of my lecture, and I'm now attempting to share this with you. Let me see. Okay, now we're starting this. Please shout out if it's not visible. So, we have been treating essential tremor and other forms of tremor for many decades now with various surgical techniques. And lesional surgery in the form of radiofrequency lesions is still, as Ludwig has told us, a valuable option, even if DBS has dominated during the last 25 years. But we are now seeing an increasing interest in lesional surgery, and that is of course mainly due to the introduction of MRI-guided focused ultrasound. And before we continue, it is important that you realize that I am not an expert on FUS as Mart or Ludwig, even if I have a long experience of tremor surgery in general. I started with FUS in October last year, and I have only treated 17 cases. And even if I'm most happy with this new cool tool, I think that we need to be careful when evaluating and comparing it to the other existing therapies. For those of you that are not familiar with the process, we start by mounting a frame on the head, and the patient is then placed in a helmet in the MRI with a silicone membrane on the head for the water cooling system. An MRI is then performed and the target is identified, and 1024 ultrasound beams are then directed towards the target point in the brain, where the energy is converted to heat. And with thermography, we can follow this procedure in real time. However, properties of the skull can affect the ultrasound beams. The skull density ratio, or SDR, is a measure of the calcification of the skull. According to the current FDA recommendations, only patients with an SDR 0.4 or higher are candidates for FUS. In this study of 246 patients from Taiwan, half of the patients did not meet this criteria, while in this study from Toronto, it was 37%. And these figures are consistent with our own initial experience in Sweden, where of otherwise suitable patients for FUS, 41% failed to reach the FDA-approved SDR of 0.4, and 27% failed to reach even 0.35. When you speak with the most experienced users, some will tell you that they will accept an SDR that is much lower, even though it will require more energy and time and might be painful. Others will tell you that they have tried but then decided to stick with an SDR of at least 0.4, since a lower SDR would result in more diffuse lesions with more side effects. And here we see the difference between a higher SDR of 0.52 and a lower of 0.39. And you see that in the latter case, the lesion has a smaller necrotic core, and the edema is asymmetric, off-center and diffuse, extending into the internal capsule. Anyhow, the procedure will start with one or several so-called low-power sonications, where the target area will be heated to about 42 degrees, which will result in a transient deactivation, and this allows for intraoperative testing. If the effect is not good, or if side effects appear, then the target will be moved accordingly and a new sonication performed. When the final target has been decided on, a high-power sonication is done to reach a temperature above 56 degrees, resulting in cell death and necrosis. And the effect is immediate, and the whole procedure will in experienced hands take about 2 hours, and the patient can return home the same day. FUS does of course not exist in isolation, and it makes most sense to compare it to DBS. And if we look at the advantages of FUS, then it is incisionless. We don't need to open this skin and bone, and the brain is not penetrated. It is a considerably faster procedure, and when FUS is working, the patient is more or less cured from the symptoms, while DBS is a lifelong treatment hiding the symptoms. The workload is much lower with FUS, and it can be performed also in very old and frail patients, and the risk for hemorrhages and infarctions is much lower, and there is of course no risk for infections or implant-related complications. Regarding the disadvantages of FUS, it is mainly limited to unilateral surgery and thalamotomies for tremor, while DBS can be done bilaterally for many indications in several targets. It is an irreversible procedure with a higher risk for transient and irreversible side effects from the lesion itself, and I believe that the effect is probably not as good as with DBS. And in order to understand the success of FUS, the patient's preferences are most important. I am a surgeon because I enjoy brain surgery. However, even though it might be difficult to understand, most patients do not actually want to have brain surgery. And the success of FUS is to a large extent driven by the patient's preferences, and the patients are not as fond of cutting and drilling as surgeons. Regarding the cost, a FUS machine is not cheap. It costs about 2.5 million euros for the machine itself, and then 190,000 euros per year in obligatory service, and then you have to add to this about 4,250 euros for each patient for the treatment kit. And in Sweden, a unilateral FUS is cheaper than unilateral DBS, but a staged bilateral FUS would be more expensive than bilateral DBS, and the radiofrequency lesion will be cheaper than FUS, and you will get 4 gamma knife thalamotomies for the cost of 1 FUS thalamotomy. Regarding the outcome, it goes without saying that bilateral DBS will reduce bilateral tremor more than unilateral DBS or FUS. Therefore, let us focus on comparing unilateral DBS with unilateral FUS, especially since bilateral FUS is not commonly performed. And if we look at the marketing information, then we will find unilateral thalamotomy to be very effective, with an average tremor reduction of 73% even after 5 years follow-up. According to this review of Giordano, unilateral FUS is as effective as unilateral DBS regarding tremor reduction, but with a better quality of life. And this has now often been repeated in various papers and presentations and seems to have turned into a meme, but some caution is necessary when interpreting the results. Of the DBS studies in this review, no less than 9 are mine, and I will use the last one of these as an example to demonstrate the problems. In the first study in this review, they were using the total CRST score, which was 56% for FUS compared to 60% for my DBS study. And then we had a well-known randomized study where the improvement of the total score was 35%. And I can mention here that the hand tremor score improved was with 40%. But then in the 2-year follow-up of the previous study, the results at 12 months have improved dramatically from 35% to 56%. But this is just an illusion. The review has here switched from the total CRST score for the whole body to the hand tremor score for just the treated arm. But the improvement here of 56% for the hand tremor score is still being compared with my total score for the whole body, even though the improvement of my hand tremor score was reported and was 86%. And in the following studies, the hand tremor score for the treated hand will mainly be used for FUS studies, and mainly compared with the total tremor score for the whole body concerning unilateral DBS, which is of course not fair. If we remove the multiple inclusions and keep only unilateral procedures, which are reported with mean values and items that can be compared with the CRST items reported in the FUS studies, then we end up with about 200 unilateral patients in each group. We then see that the hand tremor score was improved with 74% after DBS and with only 58% after FUS. Interestingly, ADL, which in the review was largely used to calculate quality of life, was actually better with DBS. How is it then possible that the quality of life was claimed to be much better after FUS, 62 versus 53%? Well, quality of life was mainly reported by using Part C of the tremor scale, activities of daily living for the FUS studies. But regarding DBS, even if ADL is reported in the original studies, scales where DBS always have a more modest percentual effect have instead been frequently used. If we look at the 4 DBS papers with the lowest quality of life according to the review, 35, 40, 37 and 36% respectively, then we find that this was with Quest, PDQ-39 and other scales, but all these studies reported also the ADL, and had that been used, the corresponding numbers would instead have been 73, 71, 69 and 68%. The mean improvement of the worst DBS studies was still higher than the mean improvement for the FUS studies. Thus, if they instead had reported the ADL in the same proportion as for FUS, the quality of life would have been much higher for DBS. So there is nothing in the literature suggesting unilateral FUS to have a better effect than unilateral DBS. If we look specifically at axial tremor, then the effect of FUS on head and voice tremor is most often not presented, but seems to be limited. If we then turn to the long-term outcome, then for the 5 years follow-up, the focus was changed to postural tremor in the treated hand, which was improved with 73%. This item is of rather limited importance if you are not an ancient Roman or adherent of some more modern dark ideology, at least compared to total CRST, hand tremor score including hand function, or even compared with action tremor of the treated hand. But unfortunately, there is not much to compare with regarding the long-term effects of DBS if you want to have the same scale and the same reported items and unilaterally stimulated patients. In the European multicenter study, CEDAW reported an improvement of postural tremor with 70% after 6 to 8 years follow-up. I published an improvement of 80% after 6 to 9 years for VIM-DBS. But in both these studies, the patients were operated more than 25 years ago, and we have since improved the procedure. And recently, we published our 10-year data where the hand tremor score was improved with 76%, and item 5.6, contralateral tremor at rest, postural and action, was reduced with 91%, and virtually no patient had any residual postural tremor on stimulation, and ADL was improved with about 49%. It is thus likely that DBS has improved during the last 25 years, so probably we should focus on the more modern studies. On the other hand, there is probably a significant learning curve also regarding FUS, and we need to remember that the published literature to a large extent consists of the early experience. We now see a continuous development regarding FUS, with improved imaging, perhaps allowing for a direct anatomical identification of the target, an ongoing refinement and understanding of the optimal target, and a development of the technique itself and especially of how to use it. And we see a trend towards improved clinical results in the more recent publications. Regarding complications, most patients will have transient side effects after FUS, but persistent side effects are also common, as reported by this very experienced and honest group, where after 2 years, 20% of the patients had still persistent affection of gait and balance, and 10% had sensory deficits. However, I find it exceedingly difficult to make an objective comparison between FUS and DBS based on the published literature. Regarding bilateral thalamotomies, There are quite few patients reported, and it's mostly the side effects that are of interest here. If we look at this study of Lausanne of 10 patients, then 3 months after the last lesion, 6 patients had persisting side effects. In the second study here of 11 bilateral thalamotomies, complications from the first lesion seem not to be reported, but after the second lesion, 3 patients had persistent affection of the taste, interfering with oral intake. In the third one of 5 patients had permanent dysarthria and discomfort in the tongue, and in the last study of 9 patients, no permanent adverse events were registered, and these were mainly transient. Stage bilateral thalamotomy has recently been FDA approved based on data from this open prospective multicenter study. It included only patients without permanent side effects from the first lesion, and they had a total of 50 patients. And CRST Part A and B improved with 60% after 12 months. Regarding side effects, they had a total of 72% of permanent side effects after the second lesion at a follow-up after 12 months. And it's interesting to note that only 2% of the patients had gait or balance disturbance after 12 months. And this is far less than what has been typically reported in studies on unilateral thalamotomies, and contrary to what we would expect based on our understanding of bilateral radiofrequency lesions. Here we have another recent and interesting publication from Toronto. It's a retrospective comparison of 19-stage bilateral FUS and 22-stage bilateral DBS patients with a mean follow-up of 2 years. There was a similar level of tremor reduction in both groups. Regarding side effects, FUS had 32% with permanent side effects from the first lesion, and then 64% of the patients had permanent side effects from the second lesions, and gait disturbances were seen at last follow-up in 32% of the patients. Regarding DBS, they report a rather high level of stimulation-dependent side effects, or independent. In total, 36% had dysarthria and 36% had gait disturbance. But 55% of these side effects were reversible when turning off the stimulation. So, permanent side effects are very common after bilateral thalamotomies, but also here I find it very difficult to make a balanced comparison with the DBS based on the published literature. And now, based on the above, my very personal opinion is that patients in need of bilateral surgery should preferably be treated with DBS, considering the very limited experience we have of bilateral thalamotomies and our limited knowledge regarding effects and side effects, especially over time. And probably patients with voice and head tremor should preferably be treated with DBS. Younger patients should also be treated preferably with DBS, in my opinion, considering these uncertainties and the not insignificant risk for permanent complications, while focused ultrasound might be more appealing in the older population. Patients not suitable for DBS due to age or other circumstances, and this includes personal preferences, should be considered for FUS. And since so many patients want to have FUS, we will have to consider a lot of patients for FUS. And it would be most valuable to have a randomized study directly comparing DBS and FUS, especially regarding the side effects. And finally, radiofrequency lesions and gamma knife thalamotomies are still valuable and cheaper alternatives to FUS. And with that, I end this short overview. And if you would like to have more detailed presentations on FUS and tremor surgery in general, then please visit the Stereotactic Academy at stereotactic.org. Thank you for your attention.
Thank you very much, Patrick, for this really clear and thorough overview, very honest, I think you're absolutely right. We do have to remember there's also DBS, and this is probably still the gold standard, especially for bilateral procedures. I'm looking forward to the discussion about, you know, how you select your patients really. But I will now like to welcome our next speaker, Marta del Alamo. She's a functional neurosurgeon working in Spain. She is a consultant at the CINAC Center, at the Ramón y Cajal University Hospital in Madrid. I had the great honor to visit her team last year, and I was very impressed by the focused ultrasound procedure in the STN. And I think it's fair to say that Marta has one of the most experiences in the world. So I'm very, very happy and thankful that you're joining us in this evening, Marta. And I look forward to your talk. Thank you.
Thank you very much, Marie, for your kind presentation and for permitting me to share my experience. I work in two hospitals. One is CINAC, where I have done most of my focused ultrasound procedures, and also Ramón y Cajal, that we have the machine since 2 years. So to start, I always start with my family conflict of interest because I have little time to spend with them. No economical conflict of interest, and also DBS. I used to operate around 40 new DBS cases every year. And when before I started focused ultrasound, I have operated more than 300 cases. As I say, most of my cases I have done at CINAC. It's a special center dedicated to basic and clinical neuroscience, trying to stop Parkinson's disease, and the chief of the center is José Obeso. We have performed all the different targets for movement disorders, more than 500 cases. We have treated not only older patients, also younger, and less than 5% of the patients were excluded because of the skull density. We are talking.
Marta, sorry, we can't see your slide if you're sharing already.
Well.
Or at least I can't.
Sorry, you can see now?
No.
Okay. Sorry, I'm gonna try.
Yep, something's happening. Yes. Okay.
Okay. But only to start from the number of cases, we have experienced that more than 500 cases, all the movement disorder target, STM, PTT, also BIM. And we are talking about other movement disorders. The most common is Parkinson's disease. And there are 4 targets in order to try to treat the 3 cardinal motor signs of PD. So we are started with the most common target and most known because of the tremor is BIN. The first paper was from a group of Israel from 2015 with 7 PD patients with a mean follow-up of 7 months. And they have a low profile of adverse events, one hypogeusia, but 3 patients have the emergence of tremor. As Patrick said, it was at the beginning of the procedure of focused ultrasound, so they were more conservative. The same group in 2022 published at 26 PTD patients with a longer follow-up, 36 months, and better results and no adverse events. The other trial from VIN, but for PD patient, not for tremor, was conducted in North America. It was a randomized, double-blind, sign-controlled trial with 27 PD patients, and they make a scale at 3 months. They have an improvement of 62%, but 22 in the same group. The only adverse event they find is mild hemiparesia, 4 orofacial paresthesia, and 1 ataxia. And because of this get the FDA approved BIN to treat the Parkinson's disease tremor. Then another group from Japan, Taira, in 2021, they published 11 PD patients with a long follow-up, 1 year. and they found only one tremor recurrent of a patient that they couldn't increase the temperature over 49 degrees, and only one dysesthesia. There is also a meta-analysis comparing Parkinsonian tremor with focused ultrasound, and they conclude that MRI phase hasn't demonstrated to be inferior to DBS. And also they say that they were in the first experience of focused ultrasound, let's see in the future, and patients from focused ultrasound were older than patients in the DBS group. Another important trial is trying to compare the cost of all the treatments, because you says the machine is very high, but in this trial, in this paper, they find that allomotomy with MRI phase is cost effective with patients with TDPD, particularly compared to all the medical therapy that you are not going to stop with the treatment. We have treated some Parkinsonian tremor patients, and we talk all the groups over the world. There is more tendency to have a relapse, and we compare our efficacy, and the patients that have the more efficacy, they have some kind of in the inferior part of the beam, trying to cover the posterior subthalamic area as a target that Professor Mustrup has very much experience, and also to encompasses a little bit of STM. That we are talking about this later on. The other target for Parkinson's disease is PTT. The first center that were the pioneers for this were the center of Jean Monod in Zurich, and they published several papers. The first one is trying to say the work that they are doing, the work that the targeting. They consider they consider this very optimized palidotomy, and they were very happy with this tool, and they at the beginning they published only 13 patients, but with a very good results and no side effects. They repeat the lesioning procedure like a clock, around clock, and they have good results. And they publish then more patient randomized and also prospective and also bilateral. One example of this is 56 intervention, 15 bilateral, and a follow-up of 12 months, and a very good reduction of UPDRS, 84%, 17 to improvement of rigidity, 73 bradykinesia, and a good reduction of levodopa. As side effect, they have 7 speech difficulties, 1 epico, and they still 10 months. My experience with PTT, we have treated only 4 patients because, as I'm going to present after, we are very fan of STN target. And we were part of an international bilateral trial. The targeting cell is easier to do, is smaller, and it's easy to increase the temperature, and we have good results, but let's see the result of the trial. GPI. The first trial was published, the first paper was one patient from Korea, from Chang, a 55-year-old with 12 years of disease. They performed 3 lesions and they have good results, reduction of EPRS 3 on 50%, and also a reduction in the dyskinesia rating scale of 53%. Then with this good experience, they perform a pilot study, an open study, with patients with more than 5 years fluctuation levodopa or dyskinesia, and then they present the result in 10 patients. There are some patients that they couldn't increase the temperature because GPI is a more lateral target, and it's more difficult to increase the temperature near the skull. But they find an improvement in quality of life. They don't find permanent side effects. Only one dysarthria and hemiparesis that was transient. And the mean reduction in UPDRS part 3 on medication was 32%, and off medication it was 52%. After this, there was published an open trial in the North America, a multi-center trial with 20 patients with 1 year follow-up, and good result. The dyskinesia rating scale was reduced 59% at 3 months, and the UPDRS reduced 44%. They found an improvement on and off. They found not very much high adverse event, 1 transient and mild visual deficit, 4 dysarthria, 2 mild and 2 moderate, 1 cognitive disturbance, 2 fine motor deficits, 1 facial weakness, and 1 ataxia. And this was the first part of, because of this, is get also the FDA approval for GPI for PD and the CE mark. There was another paper from Germany that they performed a stage bilateral focus ultrasound palidotomy, and in this paper you can see the video. It was make 1 palidotomy and another one contralateral 18 months later. You can see how they made a target and how you can see the images, and they had good results. So then the North America group conducted a multi-center international randomized controlled double-blind trial that I was part of this, and but with this, in this trial they choose the primary outcome was a response defined as a reduction of 3 points on either motor impairment scale for the TT size in the off medication state, or on a dyskinesia scale in the on medication state, with a clinically meaningful worsening in either scale at 3 months. Only 3 points. The active treatment were 69 patients, and the SAM procedure were 25 patients, and 30 of the 39 patients improved. They were a very low profile of adverse events, 1 dysarthria, 1 visual disturbance, and 1 facial weakness. So they conclude that it was you can do a palidotomy for PD, going to be likely to have a reduction in motor symptoms of dyskinesia in 3 months. It's interesting that in the SAM procedure there was a 30% of responders, and in the active group there was a 30% of non-responder. Was the 3 points. The improvement of 3 points is, from my point of view, too low to consider a primary outcome. But well, this trial conducted this. They were happy with this. From my point of view, I have done less than 10 palidotomies. It's possible to do. Well, it's true that you need to increase more the temperature, but from in my patient, I could increase in all the patients the temperature. As you are making a lesion, you need to be more conservative, and you need to be a little bit more anterior, dorsal, and lateral in order to be away from the track. So the capsula and you can monitor with the system. You can draw the optic track, and you can know how the temperature is increasing, and you will have any visual deterioration. Here you can see one example of our patient. We treated 2 of dystonia Parkinson's disease patients, 2 patients from the randomized trial, 1 PD asymmetrical and one PD. We have treated 1 PD 5 years after the STN, that the contralateral side deteriorated, and need to increase the levodopa, and he has dyskinesia, so we perform a palidotomy. Now I'm going to change to STN. This is my favorite target for Parkinson's disease. You all know very well this target is one of the most common targets for movement disorder. This is very small and is parcellated. And in 2016, we conducted an open pilot trial with 2 evaluators, neurologists, external evaluators, we have good results, improvement of 53%. Most of the patients improve. We have found different improvement in the three motor cardinal sites. The tremor improved the most, 76%, then the rigidity and then the akinesia. So we analyze our result, we change a little bit of way of doing the target. And I'm going to say later we have better results in all the cardinal signs. By that time, we didn't have this coil in the membrane. We have not at good quality of images. So I was doing the target, some kind of indirect target, and I trying to visualize the STN. Now I'm doing a direct targeting, and we move a little bit dorsal the targeting because we know the lesion is going to increase down, and a little bit anterior in order to improve the bradykinesia. With this side, we conclude that you can do STN lesions because everybody was afraid that we were going to start, and we didn't have major problems. The most consistent adverse event was the weight gain. We performed cognitive assessment at 3 months in all the treatment, and we didn't find any worsen. All the patients were discharged from hospital. We stayed them 1 day after in order to have a perform an MRI and to make a lot of studies, but we didn't have any problem. But it was an open trial, so we were asked to do a randomized double-blind control trial. So we were published in New England in collaboration with Jeff Elias from Virginia. There were 40 patients, 27 in the active group. The patient had a very good global impression of change. Most of them were very happy, and we were a little bit criticized because of a long list of adverse events, but most of these were mild or moderate and vanished in the follow-up. Here you can see one example of our adverse event. This lady that after the treatment is going to be a little bit dyskinesia. Most of the dyskinesia are on dyskinesia, and if you decrease the medication, you don't have problems. It's a little bit in the shoulder. So this result was only short time follow-up. So we published the long-term result with 32 patients at 36 months with good improvement. Here you can see one example of the patient years after the treatment, 6 months after one, and then 36 months. Also, we are very interested in trying to understand what the disease is going to be in the future if you treat the patient earlier, trying to demonstrate what you can maybe have a better outcome. So we performed an early focus 1. We treated patients with less than 5 years of Parkinson's disease. We treated 12 patients. As I said before, we changed a little bit of way of doing the targeting. So we have more improvement, not only in tremor. At the beginning was 77% of improvement. Now we have 90% of improvement. More improvement of bradykinesia, 66%, and rigidity. You can see a sample of the patients. Before and after the treatment. The most consistent side effect is the weight gain at 6 months, some mild facial asymmetry, very mild speech disturbance in one patient, and one dyskinesia. We also have performed 8 bilateral stage MRI, cephalomotomy, or nucleosubthalamic lesion with STN, with focus ultrasound. And we are only performing in the patient that in the follow-up, the contralateral side deteriorated. And we have performed only this for a trial because we are only treated asymmetrical patients. And we have good results. In 12 months, we have very mild dysarthria and very mild reduced in verbal fluency only in 2 patients. So we were happy with this, but we would like to conduct a proper trial in order to can answer the question if it is possible or not, because with this only 8 patients and 6 in the trial, we don't perform sophthalamotomy only for patients that they are asymmetrical. If they are symmetrical, we offer them the brain stimulation. We are not the only group that we are doing STM focus ultrasound. Here you can see one group from Pamplona and also one group from Valencia, and there are also group from Kiel in Germany and from Chile. And also we have compared the result of control of the tremor in Parkinson's disease with VIN of with nucleus subthalamicus, because sometimes all the groups, as I say before, we have a relapse with the Parkinsonian tremor. We control very good at the beginning, but we have a relapse after the lesion. So we found that the patient more full responder in the long-term follow-up, they are more in the group of STN. So we are happy with the STN also in tremor dominant Parkinson's disease patient. We are happy with this tool also because we have learned a lot of this. We have performed a lot of study in collaboration with our engineers. Here, example from Rafael Rodriguez Rojas, who came from Cuba and also has experience in radiofrequency lesion. And we know when we are starting to treat the patient, we start in the motor part, but in the anterior part of the motor part. So the first thing that we see to improve is the bradykinesia, and we know that bradykinesia is this part is connected to motor supplementary area, and we move a little bit posterolateral less than 1.5, and the rigidity start to improve. And when we move to the posterior part of the motor STN, the tremor improve, and this is part connected to the primary motor cortex. So we make a topography. We are trying to understand what we are doing, and also we have published this very nice study that I recommend you to study in order to know the symptomatology, the topography. What about other movement disorders? There are very few papers, and I summarize here in this diapo. You can see these are the oldest paper was from Cerquera et al. And they treat S-fragile tremor, and also I have experience with S-fragile tremor with good result of tremor control. In my experience, yes, but sometimes S-fragile have more symptoms and the patient could deteriorate, so you must be very careful that the patient is only tremor. There are also a paper from Fasano et al. That they published non-ET syndrome. They published dystonia tremor, dystonia gene associated tremor with the target VIN, 6 patients, and mean improvement of 52%, and very only hemitone numbers and 1 hemiparesis and 1 hemiparesthesia side effect. The group from Ben in 2018, they published a task-specific hand tremor with 1 patient with the target VOE and BIM. It was a case report, 6 months follow-up, and improvement, good improvement, and only 1 dysgeusia. The group from Japan, Horisawa, published a 2021 paper of 10 patients with focal dystonia. The target is VOE. So it was an open label prospective case series with 12 months follow-up and with good results and only 1 dysarthria. And also the group of Zamora, X-linked dystonia Parkinsonins with 3 patients. The target is PTT. It's an open label prospective, 12 months follow-up, but good improvement in the scale of X-fragile dystonia and very low side effects. So to conclude, there are different targets with different control of every motor cardinal sites of every movement disorder disease. As Patrick tried to explain very good, the scientific evidence is non-homogeneous at all. There are different clinical studies, one prospective, one retrospective, one blind, sample size. It's difficult to make an objective comparison. It's important the previous experience in the strategic techniques. It's important that you know what you are doing. It's not thinking about fashion, is you need to choose the best for the patient and the best in your experience. If not, you can send to another colleague, and you have to make a tailor suit for every patient. And with that, I want to thank you very much for your attention.
Great. Thank you, Marta, and all the speakers, Patrick and Ludwig. Wow, a very excellent and extensive overview of the different lesioning techniques. How to summarize? I think it's clear that RF is a very effective tool, and no matter what we think of FAS, it definitely, causes a lot of excitement and opens up new indications and a lot of questions. So let's see what the questions, if we have any questions in the panel.
I think Ludwig answered them already.
Okay, Ludwig answered that. Let's start with whatever is available now. We have when does this team want referrals from therapists for these treatments you are discussing? I'm not sure I understand the question.
Maybe I can pick that one up because I actually work in 2 different countries, and perhaps this is about the severity of tremor. When do we want those referrals to come? And I really think it's a patient decision, actually. Is the tremor bothering that patient? Are they happy with the treatment that they have in terms of medication, in terms of Botox, in terms of other therapies? Do they just want to talk to a surgeon about the options, knowing that if this gets worse, they can do surgery at some point in the future? So I think the bottom line is I would encourage referrals from therapists for tremor, even if it's about discussing the options with patients who aren't ready for surgery yet, but may be ready for surgery later. I think all of the surgeons on screen will agree that when patients have this surgery, very frequently they say, why didn't I have this 10 years ago? Why didn't I have this 15 years ago? Why have I been forced to live with this for so long before someone told me about focused ultrasound or RF or something else? And I'm never going to be angry at somebody for referring a patient because they're too mild. I think that it's also important to speak about surgical therapies to patients who aren't ready yet, but might be in the future. I think that's the question that was being asked, but of course they can elaborate if I haven't hit the mark.
I think there's a question you already answered that might be of interest to everyone. How does the choice of treatment modality, example DBS, FAS, etc., influence the selection of brain targets in PD?
I can answer if you want. Well,
Yeah.
it's important to be in I think to be in a multidisciplinary team, to need to take into consideration not only for DBS, of course, is bilateral, no choice. DBS for me, for Parkinson's disease, not focused ultrasound. If the patient is asymmetrical, well, you need to decide. You need to take into consideration the age of the patient, the MRI if it has any atrophy, any contraindication, and you need to try to recommend the patient, but also, as Ludwig said, the patient is going to decide. We are treating patients of every part of the world, and they have this idea in his mind that they wanted to be focused ultrasound. And for us, the more difficult is to try to convince that sometimes they are not suitable for this technique. But as we say, not every patient is candidate for every focus ultrasound or for every tool.
Yeah. Maury?
Yes, thank you, Marta. We have a few more questions because we only have 10 minutes left, so we'll try to answer as many as we can. Here's one for Patrick. Patrick, how did you roughly calculate the cost for RF lesioning procedure versus gamma knife and the other techniques?
Oh, it's very simple. This is not based on any actual cost of the products in most cases. It's simply what they cost in Sweden. So, and the idea is that it should be the cost without profit, but it's not always correct. So this is what you have to pay if you are a hospital referring a patient for this treatment.
I think that's an important point because Martha, you mentioned one of the papers that examined the cost effectiveness, and I think different people look at different aspects of cost effectiveness. Are you the insurer or are you the hospital? So if you are the insurer and it's the cost that you have to pay the hospital, then yes, it's probably more cost effective. If you are the hospital that has to take in all the initial cost of the equipment, and then probably it's less cost effective. So it's, you know, it's but both are right? It's
yeah, two different ways of looking at it. So this is just the cost for these procedures in Sweden.
okay. Let's,
So it's just a comment, which is patients need to know that this type of treatment exists. I think that's true, but I also think neurologists need to know that there are different types of treatments, and it's probably our job to educate them. And I think what is your feeling? My feeling is that since we have focused ultrasound, we get more referrals, but we then decide to do DBS or RF. Is that I see you guys nodding. Is that also your feeling that focused ultrasound has helped to bring functional procedures back on the map and make it a bit more, let's say, human and accessible for neurologists as well?
Yes, I agree completely. This incisionless therapy is more palatable for neurologists and especially for patients, and they will start seek help to a higher extent. And then we get the option of also discussing with the patients that might not be suitable for FUS and suggest other therapies. So it has improved the situation.
Yes. There is another interesting question. Ludwig answered it already, but I'm going to ask it and get your opinion from a different point of view. So is RFA much cheaper than FUS? And what about the accuracy? And Ludwig, you said that RFA is much cheaper, but once you have a FUS machine, you want to use it. Can you just tell us a little bit about the pressure that you have when you've made a business plan and you need to show your hospital that you're using the machine? Does it change the way you speak to the patients if you're very honest?
I mean,
Well,
I
would
sorry,
say,
is that for me or for Patrick? Sorry, go for it.
okay. So for me, I
all-
start. I would say no, it doesn't change, but there is a pressure. I mean, now if you buy a radio frequency system, it doesn't cost anything, and if you don't operate patients, you will not lose a lot of money. But when you have paid this sum and bought a focused ultrasound, then you will have an interest in covering your costs. So I guess you will be more interested in finding patients. In our quite socialistic system in Sweden, this is not a problem. We try to find patients, but we don't feel a big pressure to recover the cost.
Good.
But it might be in other systems.
Ludwig?
I think Patrick said it all, really. I mean, we're very lucky when you work in a national healthcare service or in a social healthcare, where there is there's the distance between the patient care and the money that the doctor makes, and certainly the money that's being spent on a treatment. I think it's really nice that we have all modalities. But I think if you're working in a healthcare system where money is key, when you need to make a profit or at least break even, and it is a cost consideration, even in a social healthcare system. You know, if you've bought a focused ultrasound and you've done 10 patients, and it cost you a 2 million operation, 2 million investment, that's a very expensive £200,000 per patient. If you've done 150 patients, well, then that's much cheaper in terms of cost efficacy. My main fear is that we favor one treatment over the other rather than listen to what the patient really wants. You know, if the patient doesn't want to shave their head, we shouldn't be pushing them away from towards focused ultrasound. Likewise, if my preference as a surgeon is doing RF because I think it's nice and quick and it's a operation I enjoy, I shouldn't be pushing them towards a radiofrequency ablation. So I think we just have to keep our doctors' hats on before our surgeons' hats on and our financials hats on, and do what's best for the patient in front of us. But I think before you embark on buying a focused ultrasound machine, if you are a center that does that, I think you do have to make considerations of what the financial aspects are going to be, because it's not just the capital costs, it's the ongoing costs. And 80% of the world can't afford a focused ultrasound machine, and an RF is a very, very good operation that most centers around the world can afford.
So I have a question to the panel. As someone who does stereotactic functional surgery, and we don't have the funds, but we are considering buying it. What is the learning curve? So to start doing it, after how many procedures do you feel comfortable? How long does it take to incorporate it into your system?
I can answer that first, I think, and I can say that after 17 procedures, you still are just in the beginning of the learning curve. So, Ludwig, when do you feel confident?
So I think there's a lot of transferable skills. So, if you've never done an ablation in your life, there's going to be a much steeper learning curve when you're doing focused ultrasound. I think if you've done loads of radiofrequency ablation and you're coming to focused ultrasound, there's still a lot of technical aspects that you need to learn, but at least you have a good handle of the location of the lesion and the size of a lesion and the side effects that one might encounter. So I think there is a learning curve, whatever way you come into this. I don't know what you can pull a number out of the air, can't you? I don't know how many hundreds of radio frequency thalamotomies I've done. I still feel that I'm learning, and I still feel that I can make nuances in saying maybe I shouldn't do 70 degrees with every patient, and I should lower the temperature or lower the time or change the needle that I'm using. So I think the first 100 patients, you're on a steeper learning curve than the next 100. But I think if we stopped learning after 1,000 procedures, it's probably time to hang your hat up and appoint somebody who's still going to make learning improvements and increments, because you should never stop learning.
Marta, can I ask you?
Yeah, I think if you have experience in not only in lesion, if you have experience in stereotactic procedures, it's much more easier, because you know how to deal with the different side, with the different targeting. Targeting is the most important thing. So I think I have never performed a lesion before I started focused ultrasound in 2015. I think it took me, I would say, 2 years, because at the beginning the first year we were doing only BIM, and the second year we started with STN, and STN is a little bit more difficult. But I think after, I will say, 50 patients, I wasn't afraid, because at the beginning I was completely afraid, and now we feel very comfortable. But we always have different things, different new things, because, for example, this morning I have one STM patient, and it was so difficult to increase the temperature with a low SDR, and skull thickness, it was 7 millimeters, it was impossible to increase over 52 degrees. So it was very difficult. We couldn't stop at all the sign, the motor signs. So you are always learning. But I think the first thing is not harm the patient, first not have side effects, and to be at the beginning you go very slow. You do a big number of sonication, and then you are going fast and fast with good not side effects. And also the other thing that you are talking about, I think not every hospital need to have their own focused ultrasound machine. In Spain, we have too much focused ultrasound machines. It's because we are not the doctors who decide to buy the machine. They are the politicians who decide to buy the machine. So we have too many centers. I think it's better to be well organized and to have a big reference center as Patrick, for example, and you, with a big population, and to cooperate, to work together, because instead of that, it's too expensive. The system is too expensive. because it's not only the cost, it's every year you need to pay for the maintenance, so it's too much expensive.
Okay, thank you very much. I think these were nice ending words. First, do no harm. It's 5:30 here, I think 6:30 in many other countries. So we have to close the session. I would very much like to thank all the speakers again for excellent talks and a really nice discussion at the end. I hope that those of you who have joined us tonight enjoyed it. It is being recorded and you can watch it again if you like. And I'll get Ido to say the final few words. So good night from me.
Thank you, Marie. I think if I will be a bit provocative and leave the question open, I think I started the session thinking, what is the role of lesioning or FAS in the modern functional surgery, and with all the new indications that Martha showed us, I think maybe we will ask what is the role of DBS. Can we lesion everything, and who is the suitable candidate for DBS? So that is probably still an open question. We don't have an answer. But yes, thank you. It was an excellent webinar. Thank you all.
Thank you all.
Thank you. Thank you.
Bye-bye.